Welcome to Brain Talk, a podcast from Project BrainStorm about the bipolar spectrum. Your hosts are Dr. Jim Phelps, a psychiatrist and author of several groundbreaking books about bipolar, and Sara Schley, author of the memoir Brainstorm, From Broken to Blessed on the Bipolar Spectrum, and co-creator of Brainstorm the Film, coming to you in 2025. Here on Brain Talk, we'll interview new experts each week about their research and expertise within bipolar, and listeners will call in to ask questions. Let's work together to save lives, end the stigma, and create healing for everyone on the bipolar spectrum and those who love them.
Good morning, Dr. Phelps.
Good morning, Sara Schley. Nice to see you as always.
Yeah, good to see you too. So what's happening out there?
We have both of our children here at home for a bit, always a gift. So that's been the main focus just lately.
That's so nice. Yeah, when the big ones come home, that's nice. Today we are really blessed to welcome Dr. Crystal Clark. She's an amazing person and psychiatrist, and she is, I believe she'll refer to herself as a perinatal psychiatrist or a reproductive psychiatrist. I was really amazed to meet her. I didn't even know such a specialty existed.
I'm not sure that I would have recognized it as a separate specialty up until fairly recently. But in anticipation of our visit today, looking at some of her publications, wow, it is, she has created a field.
Yeah, and the thing is that's crazy, of course, we know this, but women make up relatively half the population, and yet most of the research in science has been done by and for men. Is that correct? Because I know you're an equal opportunity practitioner. What's the impact been for you in your practice?
You start to learn things one little bit at a time. Lamotrigine needs to be adjusted during pregnancy or may need to be adjusted. Have to be heads up to that.
I also know that there's a huge incidence of postpartum depression itself that was never recognized or screened for. Now people are screening for that more, but then there's also postpartum bipolar depression, which is even less, discovered for all the reasons we've been talking about on this podcast. So Grateful and lucky to welcome Dr. Crystal Clark. Dr. Crystal Clark, welcome to Brain Talk, and thank you so much for joining us this morning.
Such a pleasure to be here. Thank you for having me.
So help us understand, what is reproductive psychiatry or perinatal psychiatry exactly?
Yeah, so I like to call it where the hormones meet the mood. And so that could be any time in a childbearing person's or woman's life. So from the time our menstrual cycle starts all the way to perimenopause and menopause.
Wow, that's a very cool description. Had you heard that, Jim, where the hormones meet the mood?
It's a good one. And no, I think that is your coinage, Crystal. I wrote on my website years and years ago, my patients have been talking with me we've been talking about hormones and mood. I should write a page on that on my website. So I have the page titled Hormones and Mood. It's Oh God, what are you going to say? Oh, gee, doc, have you just finally figured out that hormones have something to do with mood?
Right.
So how has that influenced your practice? Who you see and what their issues are and how you show up in your work?
Yeah, so, we know from menstruation starting, that's when, young girls start to have more hormonal dysregulation and impact. And that's when we first start to see depression and anxiety and other mental illnesses onset. And I like to say where the hormones meet the mood, because it's not just what's happening to us physiologically, just naturally. It's also, infertility treatments and having exogenous hormones. It's also using birth control. We have patients who respond very poorly to the hormones that are in birth control pills. So anytime the hormones are impacted, that then leads to some change in the mood, that's when I'm saying, come see me.
So Jim, when you were practicing, would you like to have a Dr. Crystal Clark in your network?
Indeed. I'm not a dimwit when it comes to understanding where hormones meet mood. But there's just so much to this. But you operate in a system where you are available as a consultant, the collaborative care system that you built there.
I think collaborative care is so important, and I hope to see more and more models. I think it should be a standard of care until we have that dual training program between OB and
Right.
psych. I think we have so much more to understand and really working together collaboratively in a multidisciplinary fashion.
I had got my bipolar diagnosis finally at age 47, 6 after 25 years of dealing with this, thanks in big part to Dr. Jim Phelps diagnostic, which my guy used, and he's a psychiatrist who is an expert in bipolar. However, 10 years later, when I started going through perimenopause and I'd been completely stable, I had a severe relapse, and no one, not
Yes.
no one had any idea that this was connected to perimenopause. Not my
Yeah.
regular doctor, not my therapist, not my friends, not any other, and not my bipolar expert,
Yes.
doctor, psychiatrist who was, God bless him, in his 70s. But it's like no one knew. And
Yeah.
now we know that this is a thing, right? So do you want to say a little bit more about that?
Yeah. So now we know that as these hormones are, well, the estrogen is dropping, right? And that's causing all types of physical symptoms, hot flashes. It's one of the most common things people complain about in that transition. But we see new episodes of psychosis where people are having bizarre thoughts or delusional paranoia. We also see significant increases in anxiety. For people who are like, I never felt this way before. I've never felt like this. What is wrong with me? New episodes of depression, and definitely for people who have had a diagnosis before, we will see it recur in a way that's odd because, like you said, been stable for years, decades, and all of a sudden, this transition where the hormones are dropping, the estrogen specifically. And now we see this huge impact on the mood for many. We need more answers for this.
Isn't it interesting? I think of it like it's antidepressants can make people worse when you put them in, and then antidepressants can make people worse when you take them out. And so here's estrogen, which when in puberty, estrogen levels are going up in various stages, like
Right.
with birth control pills, you can mess people up with estrogen and progesterone. But then here's people getting messed up when it's going away as well. It's like,
Yeah.
wait a minute, how can this happen in two different directions?
Yeah. Yeah. No. And that's a great question, Jim. Some people experience these mood changes with their menstrual cycle because there's a change in the hormones throughout the month. And as they get closer to the period, the hormones are going up. Those same people will likely be more sensitive to having these symptoms occur in pregnancy and postpartum because, again, you have the hormones going up and then going back down. And those same people, when they go through the menopausal transition, will respond similarly to that dysregulation of the hormones and kind of going up and down. And although they're kind of collectively declining in the perimenopausal phase, there's still this like up and down throughout that phase that is really wreaking havoc in a
Right.
new way.
Wreaking havoc. I thought of it as like Jim, really appreciate this metaphor because you used to be a whitewater guide, if I recall in your history. I thought of it as like going through whitewater, like hormonal whitewater during panorama. Hang on for dear life, which it's tough enough for regular people, but then if you've got bipolarity
Right.
on top of it, I could throw out one statistic that I know from one of your colleagues over in the UK. You may not have met her yet, Claire Dolman. She's a psychologist who we're hoping to have on the show. She lives with bipolar. She's also a researcher. They're amazing, way ahead of us in England, I think, way ahead of us in the States. And she did a qualitative thing out of 1,000 people that she asked with bipolar during perimenopause, how many did not hear anything from their doctors about the possibility this was a problem? 90%. How many actually had a problem? Close to 60%.
Yes.
So,
So, question there, Sarah.
yeah.
Dr. Clark, do you think that women who have more mood symptoms with each monthly cycle, are they more likely to have mood symptoms when they go through perimenopause?
Yes, absolutely. They're definitely more likely to have symptoms because we've already seen kind of the trajectory of a abnormal sensitivity to this typical hormonal dysregulation.
Yeah, that's it.
Yeah.
And one more thing on perimenopause while I'm on my pedestal, Jim. So this is perimenopause, the years leading up to menopause. People think, I would suggest, oh, they're all ladies. What do we care about them? It's like, we'll just stick them on a float and push them out to sea. But guess what? You're in your high 40s, early 50s. Yeah. You have parents that need you or are dying. In my case, my mother was dying. You may have teenagers at home, which I did. You may have a full-time job, which I did. You may have a husband who is dealing with health crisis. I did. So to have your life just completely devastated, that moment when you're in your prime, like my friend calls us the keystone species, like the wolf is an ecosystem, that's a problem. So let's get more research. Let's get more practice. Yeah. And what, if anything, would you recommend for women that are approaching or in that phase right now?
I definitely, for those who have a history of any type of mood disorder, bipolar disorder, depression, anxiety, that's when you definitely want to seek out a reproductive psychiatrist who might have a little more of a clue. We don't have all the answers, I promise you, we don't. We're still researching this. And a good gynecologist. There are some menopausal centers in different cities around the country. And I say that because it's really not a one size fits all. The standard of care, the first line is like start an antidepressant, what we know as SSRIs. If not that, maybe start hormones. But I can tell you that is not the end all be all for all people. So, I have some patients doing acupuncture, trying supplements, of course, all the lifestyle things, exercise, like that can be hard to do when you're feeling the worst, but keep pushing forward with that. And just really working closely with the team to try things until you find something that works for you.
I'm sure there's a lot of people right now who would like to have you on speed dial.
Yeah, no kidding. So, Crystal, in one of your papers, speaking of things that can be done instead of antidepressants, for example, in one of your papers, I'm just going to call the quote here. You said, psychological treatments are effective and preferred by many perinatal patients over medications, but they often remain inaccessible. I wondered, are there specific therapies in your mind that you were referring to there in terms of perinatal psychiatry?
Yeah. So when we're thinking about referring someone out, no matter what phase of life they're in, but needing additional help, especially specialty help, such as for postpartum depression or perimenopause, trying to find a therapist who also has a clue about that particular lifetime phase or whatever is hard. It's not many, and sometimes general therapists just don't have as much skill around that particular topic. There are clearly therapies such as cognitive behavioral therapy or interpersonal therapy that we also refer people to, and even if they don't have a specialty in reproductive mental health, these therapies can be helpful.
We maybe should mention in that context, and you may have used it, there are online versions of cognitive behavioral therapy, CBT. So, for example, the one from Australia called MoodGym, which costs $30 for access for a year. MoodGym, one word, GYM, like gymnasium. MoodGym from Australia, available to anyone. It's amazing. Their National Health Service built this whole program. It's been tested and tested and tested, and available to anyone around the world for English speakers. It's really a gift.
So, Crystal, I know there's a lot of people out there who have experienced postpartum depression or are currently in a postpartum depression. Their loved one is in a postpartum depression. It's pretty much an epidemic. Can you help us out there? What have you seen? How do you help your patients?
So we know that 1 in 5 globally are experiencing postpartum depression or anxiety. We have to always remember anxiety because we've been lumping it all under postpartum depression. And postpartum depression is including patients who might have had a history of bipolar disorder or major depressive disorder, or it's like a brand new onset right after delivery. And how I'm working with those patients, ideally, I'm seeing those who have a history of anything ahead of time. Especially my patients with bipolar disorder, thankfully, are more likely to come in and try to plan around their medications and things, and following them through postpartum, trying to make sure, to the best of our ability, we're working together to prevent an episode, because we know those with bipolar disorder have a higher rate of recurrence during the pregnancy and postpartum. Patients who present new onset, I'm trying to like educate them about it. And I'm always educating my patients, period, whether they have a history or not. A lot of people just don't understand postpartum depression and the risk for it. But people who have never experienced mental illness and come in for the first time postpartum they're just beyond themselves. Like, how did this happen to me? What did I do wrong? My life is fine. It was, I'm happy to have a baby. Why am I feeling this way? So it's a lot of psychoeducation, and then, making sure I support them in their options and making the choice for treatment that's best for them and their family.
We have one colleague, Devika Bhushan, who's in the film BrainStorm, and she was told by her psychiatrist, "Oh, you have bipolar. You don't want to have a baby. You don't want to give this to someone." And thankfully, she didn't pay attention. She's got a beautiful
Yes,
5-year-old.
thankfully.
But what would you say to your patients who live with bipolar, who come to you and say, "Can I have a child? Will I, screw them up? Can I stay on my meds? Do I have to get off my meds? We used to think you got to get off all your meds." Is that a good idea?
No.
Absolutely not. I say to my patients, we can do this, okay? And we can do this safely. I've never understood that advice of, you have bipolar disorder, you might pass it on. Well, it's a lot of things that could be passed on. There's things that's passed on we don't even know we have in our gene pool from our relatives. So I tell them we can do this. Absolutely.
I love that phrase. Jim, can you imagine going to your doctor and she says, "We can do this"?
Yeah.
But in terms of medication, no, I actually encourage my patients, particularly with bipolar disorder, to stay on them. Of course, there are some that are contraindicated. Again, the goal is to do this as safe, low risk as possible. So there are a couple of medications. I'm like, if the patient's taking that, I've probably tried to get them off of it well before they became pregnant in the first place. But for the most part, whatever is working for the patient, they should stay on. And then we monitor and try to adjust accordingly.
So to some, women with bipolar can have children and they can stay on their meds. We got a plan. We're going to tweak with a good, doctor working together. We can do this.
It's funny you mentioned, this, because I keep thinking we're past that. We're past the days where people are being told they can't have children because they have bipolar disorder. But I did have a patient a few years ago who had that very, very story. And her mother even came in to convince me not to let her move forward with her plan to have a child. And she's had 2 since then. And she had healthy pregnancies and the kids are doing great. And so I share that to say, yeah, we can do this, which is what I told her. I was like, no, we can do this. And I worked really closely with her OB-GYN and we were, tweaking. She was on she was on lamotrigine for anyone out there who might be taking that medication. Yeah. Very, have to be very careful with monitoring it during pregnancy and increasing it as needed to control bipolar disorder symptoms. But we did that. We monitored her closely, carefully. She had no recurrence of anything. And her kids, she sent me a picture the other day.
So great. I know this is going to sound corny, but that's the greatest joy of my life are my 2. They're 22-year-old twins, right? They turned out okay.
So, Crystal, is it the majority of medications that need to be monitored and potentially adjusted during pregnancy?
So I would say based on my research, yes, and to different degrees. Now, some are going to need more monitoring, more adjustment than others. And I would say actually only a couple need like significant adjustments in pregnancy, whereas others, it depends on that individual's the way they clear the drug through their body, the way they metabolize it. So someone might be a really efficient metabolizer or rapid metabolizer, as we may say it, where they're just pushing things quickly through their body, quicker in pregnancy than others, and others may be really slow metabolizers.
Since we know that particular metabolizing enzyme that changes during pregnancy, do you use the genetic testing to identify in advance who's a slow and who's a fast metabolizer?
Yeah, great question. I do sometimes use the testing when it's accessible. That's another thing we need to have accessible to everyone.
I think when we interviewed for the film, correct me if I'm wrong, but this stuck with me and our director, was that it just seemed like so much common sense. You're pregnant, you have more fluid, more body mass and more fluid. So wouldn't the concentrations of your medication go down in the body, in the blood? So you might need to bump them up in terms of how many you take. That just seemed kind of obvious. Is that true sometimes?
Yeah, no, it's absolutely true. Sometimes I think that it just makes sense that some people are going to have loss of effect of their medication.
Crystal, since our show is about bipolar spectrum or mood spectrum, if someone comes into your office and it's the first depression they've had, because we know that some people get a bipolar depression for the first time after they're first born, right? They may not have had an experience prior. So they come into you with depressive symptoms, the standard ones. How does a doctor know if this is regular depression, like major depression, or a bipolar depressive episode?
As someone who is a bipolar disorder expert, I'm always looking for it. But I've had patients where until they were postpartum believed they had major depression, not bipolar depression or bipolar disorder. And postpartum, just kind of brings things out. So, have a new onset. And I can remember a case in which a patient who we thought was just, typical depression. She presents with what I felt was an agitated depression postpartum. And my alarms went off. I'm like, this looks like bipolar disorder, but she was denying every symptom. She refused to take a mood stabilizer because I could not convince her that she had enough symptoms that met the criteria. We let her take an antidepressant with the plan to monitor very closely, looped in the family. She ended up becoming manic on that antidepressant. So I tell when I talk to my students, my colleagues, my trainees, number one, I'm saying use another scale, a mood disorder questionnaire, for example, the rapid mood screener, something for these people who present with depression. And they might still deny all, like, no, this doesn't fit me. If you have a hunch at all, monitor closely. And we know that bipolar disorder has a 50% greater risk of having a new episode in the postpartum period. So if you're going to start antidepressant, you want to see them, in a week or two. Tell the family, tell them to look out for these symptoms because we don't always know.
Crystal, you said if you have a hunch, here's this person who doesn't meet criteria for a bipolar disorder, and yet you still have a hunch. We've talked on this program about there are ways to develop a hunch that don't have to do with symptoms. And this was key for Sara.
Yeah, it came out of your diagnostic, thank goodness, Jim, because my symptoms looked like classic depression. This was how I was diagnosed with bipolar. And it was like, I call them Jim's 4 dimensions, but it was family history. So my doc goes, do you have anyone in your family with any mood issues? Well, yeah, it was my mother, my grandfather. And age of onset, when was it? Well, yeah, it was under 20. And course of illness, was it response to treatment, Jim? And they said, when you were given an antidepressant, did it seem like it worked and then make you worse? And those questions were the ones that got my doctor to go, check, check, check. Okay, this is what you have. Because it was the depressive symptoms plus those things. And then what's course of illness, Jim? That's your 4th one, right?
How wobbly has it been? Is it episodic? And ironically, here we are talking to Dr. Crystal Clark, but sometimes forgotten in course of illness is not just episodic, but postpartum, a postpartum onset of depression. So someone could be being interviewed by a psychiatrist or a primary care provider, not just after their pregnancy, but years later. And if they include in their history that, yes, I had a postpartum depression, that is a feature that statistically increases the probability that what looks like depression has enough bipolarity in it that it needs to be treated differently. When you say mood stabilizer, which ones are you thinking about? Like, we could use an antidepressant, or we could use, you're right here in kind of the middle of this mood spectrum. What mood stabilizer with antidepressant effects would you choose?
Lamotrigine is definitely a go-to for me. Helps with bipolar 1 and bipolar 2, but more bipolar 2 than bipolar 1. Right. A lot of people feel like, oh, no, you can't use this for bipolar 1. I've seen it work plenty of times. It just depends on the patient.
So here I am over here with my lamotrigine, which I love my drugs, right? And we're not prescribing any drugs out there, but once I finally got my diagnosis right, steady, beautiful, no side effects. And then, thanks to Jim Phelps, what I added after my perimenopausal disaster was just a very tiny, what they call low dose lithium. And Jim says that low dose lithium and high dose lithium are like two different drugs. So now I've got this lithium lamotrigine. It's like a beautiful combination.
Yes.
And so far, God willing, may continue to be so. Stability. So I'm glad to hear you say that works in pregnancy. I'm beyond my childbearing years, but there are some other subjects. You've written an amazing paper that I've got it up here. Rates of major depressive disorder and bipolar disorder in Black and white postpartum women and the distinctions there. It's really cutting edge. What are you finding, and what can we learn from it?
Yeah, well, I was really excited to have that publication come out. That work is with Dr. Catherine Wisner and Taylor Birchfield. This is one of the first papers to highlight bipolar disorder in Black women. And it's just there's so many areas where we have gaps and we need more research, and this is definitely one of them. And it showed that actually Black women had higher rates of bipolar disorder, which might be linked to higher rates of trauma as well. There might be some association, but given this large sample size, 10,000 women screened who, it's like 10,000 women, and it dwindled down to, those who screened positive on the EPDS, and then those who, with a diagnostic assessment, were actually diagnosed with depression or bipolar disorder or another illness. And amongst them, that was about 20% of Black women who screened positive on the EPDS diagnosed with bipolar disorder, compared to about 11-12% of white women. So.
Wow, that's very significant.
So let me just state it and make sure I've got it right. I wrote down, you found similar rates of major depression, but almost twice the rate of bipolar in Black women compared to white women. So in Black women versus white women, similar rates of major depression, but almost twice the rate of bipolar.
In postpartum, right?
Right, in postpartum. Yeah, and I want to underscore that finding too, Jim, about similar rates of major depressive disorder in the postpartum women between Black and white women. We need more studies for sure. I don't want anyone to take this as the end all be all.
So then, Crystal, just in terms of practical implication, if you're a Black woman, postpartum Black woman listening to this program, or family who's suffering from postpartum and you've got depressive symptoms, maybe the mom is saying, whoa, maybe we should check for bipolarity, or what would you recommend?
Yeah, I would say, number one, we know that depression itself is 1 in 7 women, and that's any woman. So, Black women are not excluded from this. Definitely get checked for postpartum depression. But on top of that, make sure to be screened for bipolar disorder, because just because you have positive symptoms for depression doesn't mean it's depression. And there might be a higher likelihood that it's bipolar disorder.
Thank you for that. Wow. So much more to ask and to learn, but we're going to have to let you go for now. I'm sure you've got a million things to do out there at the University of Toronto, right? Is that where you are, Crystal?
Yeah. So yes, I'm from Chicago, but now at the University of Toronto, and plenty. I was keeping myself busy, to say the least.
I'm sure.
Anything in closing you want to share with us? Perhaps a message of hope for women living with bipolar who want to have children or have had children?
Yeah, well, I would just want to share to all the women out there living with this disorder, all the childbearing persons out there living with this disorder, that you can have children, you can expand your families. It's just finding the right help, the right support. I have seen so many through my studies and through clinical care get better. I keep in touch with several. They keep in touch with me, sharing their latest pregnancy. Now they know what to tell their doctors when I'm not around. So some of my patients in Chicago are like, just so you know, I had another baby. I stayed on my lithium, FYI. It went well. So it's, I would end by saying we can do this. You can thrive, live the life you want to live, and don't let bipolar disorder stop you.
Wonderful. Thank you so much, Crystal. Dr. Clark. Well, wow.
Yes, indeed. Again, such important stuff. And so wonderful that someone like Dr. Crystal Clark is really pursuing it in the way that she has.
Yeah, I mean, it's talking about impacting millions of women around the globe, right? I mean, perimenopause, 100% of women with bipolar are going to go through perimenopause, right? As long as they get that far. And, like you said, 50, I don't know what the percentage of women are most likely to have children, but she's going to impact a lot of folks. And I'm just grateful to know that she's out there and that we have this specialty now.
And, again, Sarah, wonderful for you to have organized this whole thing so that people around the world can find out what Crystal Clark is doing. For me, even, I wasn't aware until I started looking at her publications, like, wow, look at all the stuff that she's done. So thank you for creating a forum where you and I together can showcase her work.
Well, thank you for saying yes, and long live Dr. Crystal Clark and her colleagues. We want to thank again our producer, Luke Medalla, who's behind the scenes, and co-editors being Luke and Hannah Krantz. And we'll see you next week.
Thanks so much for joining us on BrainTalk, our bipolar spectrum podcast. BrainTalk is a program of BrainStorm, a multi-platform project about the bipolar spectrum, which includes Sara Schley's memoir and a full-length documentary coming in 2025. We aim to save lives, crush stigma, and maximize healing for all people living with bipolar and those who love them. For more information, head to www.brainstormthefilm.com. To call in to a future episode and ask questions, go to brainstormthefilm.com/podcasts.